I'm Don Edmondson. I'm the director of the Center for Behavioral Cardiovascular Health at Columbia University Medical Center. But I'm here today in my capacity as the PI of the NIH Science of Behavior Change Program's Resource and Coordinating Center. And I'm actually going to be introducing our speaker today on behalf of Dr. Ian Cronish, who leads the Columbia Roybal Center for Fearless Behavior Change. He and Jeff, and to some extent I, have followed one another. Certainly, I've followed Jeff's work for a long time. Ian certainly has, and I know they have a number of connections. Dr. Huffman has been a major influence on the field of psychocardiology, behavioral cardiology. He is a psychiatrist by training, but his work has really moved forward the science of behavioral cardiology, specifically for people who've experienced acute cardiovascular events, particularly acute coronary syndrome, which is a realm that our team at Columbia is very interested in. So his formal presentation or his formal introduction, Dr. Huffman is a professor of psychiatry at Harvard Medical School and the director of the Cardiac Psychiatry Research Program. His work is focused on developing scalable clinical interventions to improve mental health and health behaviors in people with heart disease and related medical conditions. This includes developing a positive psychology-based intervention program to promote physical activity among patients with recent acute cardiac events and those with more chronic conditions. His work has led to more than 180 peer-reviewed publications, and he's received funding from multiple NIH institutes, the American Heart Association, the American Diabetes Association, and the Templeton Foundation. And I can tell you that a number of scientists have followed in his footsteps. Many of our rising faculty are really right in his wake, bringing positive psychology to the study and interventions around cardiovascular patients. So with that, Dr. Huffman, thank you so much for being here. We have a big audience today, and I know they're excited to hear from you and not me. So I'll turn it over to you now.
All right. Thank you very much, Don, for the very kind introduction, and hello, everyone. So as Don mentioned, today I will be discussing the development and testing of a positive psychology-based intervention to promote physical activity, initially in patients with acute coronary syndrome, but we've also extended this work to try to help better manage patients who have diabetes or other chronic medical conditions. Hold on. Uh-oh. There we go. Okay. So taking a look at the big picture, physical activity is really good. So this is an analysis from 660,000 people. And here on the y-axis, you can see risk of mortality. And on the x-axis, you can see exercise levels, the amount of exercise that people do. And as you can see, there's a nearly linear, especially until you get to very large amounts of exercise, relationship between exercising more, being more physically active, having greater leisure time, moderate to vigorous physical activity, and being less likely to die. It is a very powerful protection from early mortality. Physical activity is a good thing. Physical activity is also a good thing specifically in the group of people who have an acute coronary syndrome. So in acute coronary syndrome, a heart attack or related cardiovascular event is suffered each year by more than 1 million Americans, more than 7 million people worldwide. And that period following hospitalization for ACS is a very vulnerable one for patients. More than 20% will be rehospitalized for heart disease in the next year or will die, often from heart disease in the next year. And physical activity, like with other people, is really good for people who have suffered an acute coronary syndrome. People who engage in physical activity at recommended levels are much less likely to experience recurrent events, much less likely to die in the next year. Unfortunately, most post-ACS patients are not able to complete physical activity at levels recommended by multiple organizations. And indeed, the vast majority of patients are not completing recommended level of activity many weeks after their ACS. despite the fact that they are cleared by their cardiologists and other medical providers to be fully active. And there's lots of reasons for this. Patients may not have been very active before their ACS. People may be afraid of having recurrent cardiovascular events. Or people may just not feel very motivated or optimistic about themselves or their health or their life. And that too can impede getting started with and continuing with physical activity. The good news is that there are lots of effective programs to promote activity in people who have an acute coronary syndrome. Cardiac rehabilitation is a great example. So these are often outpatient programs several times a week that provide supervised exercise, dietary counseling. Often there's a psychological component. They're great, but they're often utilized at really low rates. About 3/4, probably more, patients who are referred to cardiac rehabilitation, who are recommended for cardiac rehabilitation after an ACS, never attend. And there are lots of reasons for this. Many people don't have time, finances, transportation, or sort of motivation or kind of the cognitive sense that this will help. That going to something 3 days a week that might involve extensive travel and frankly a lot of work may not feel like it's something for them or will help them. And unfortunately, people at the highest risk of cardiovascular events or mortality appear to have the lowest attendant rates of something intensive like cardiac rehabilitation. And even for those who do attend, cardiac rehabilitation often starts weeks to months following the ACS, and often this window, this kind of teachable moment of, this may be the time for me to make behavior change in my life, may have passed and motivation may have dropped. There are other techniques and approaches to increase physical activity in people who experience an ACS. So motivational interviewing, a kind of health behavior or behavior change technique that helps to resolve ambivalence and to help people increase their internal motivation, can be delivered remotely, like by phone, and more promptly in post-ACS patients to help them start to move down a pathway of contemplating making behavior change, like getting more active. It's been used successfully for changing behaviors like smoking cessation and even physical activity in post-ACS patients. And it's been effective in promoting activity and self-care in a variety of other cardiac populations, like patients with heart failure or arrhythmias. Now, the problem, though, is that MI by itself may not be enough. In 4 recent randomized trials in cardiac-related populations, the effects of motivational interviewing alone was relatively small on physical activity. And this may not really translate into either sustained physical activity or to lower rates of cardiovascular events. And there are specific groups of people, of patients, who may benefit less from motivational interviewing and related behavior change techniques. Those include people who don't expect to improve, those who have low levels of overall optimism, or those people who have low levels of perceived social support. Certainly, psychological factors may play a role both in engaging in health behavior techniques and in getting physically active. Among people who suffer an ACS, those who have a clinical psychiatric diagnosis certainly suffer a lot, and it's very hard for people who have a clinical depression to make behavior change, especially getting physically active. It is now pretty well established that depression, clinically diagnosed, is a pretty clear risk factor for poor prognosis among patients with an ACS. And in fact, the American Heart Association now 7 years ago actually deemed depression as a cardiac risk factor among patients with an ACS. But the thing is that people, many people with an ACS don't have a clinical psychiatric diagnosis, but many of them experience distress, and many of them have low levels of positive emotions, positive cognitions. What about these? Well, positive psychological states and traits, things like optimism, altruism, gratitude, happiness, life purpose, these are not simply the flip side of depression. They are not simply the absence of depression. And indeed, when people look at relationships between some of these positive psychological well-being states and depression or anxiety, there's actually very modest inverse correlation. For example, optimism and depression are only modestly inversely correlated. And this in some ways makes sense. We've all met people who are depressed, but yet are optimistic about feeling better and getting better. And in contrast, we've all met people who are not depressed, but really not very optimistic. Importantly, positive psychological well-being is strongly associated with superior cardiac and overall health outcomes. Whether it's optimism, measured by validated measures, or life purpose, or positive affect, or positive psychological well-being measured multiple ways, the literature has really consistently found that these positive psychological well-being constructs are prospectively and independently associated with lower rates of getting heart disease, lower rates of dying from heart disease, and lower rates of overall mortality. And these relationships appear to be independent of sociodemographic factors, independent of medical severity at the time of assessment, and they appear to be above and beyond the adverse effects of depression and anxiety. There's an additional benefit conferred by having more optimism or more happiness, as opposed to just lacking depression or anxiety. Our group looked a little bit at specifically patients with heart disease and whether positive psychological well-being was beneficial. We conducted a systematic review and meta-analysis, and we looked at 8 studies that examined rates of rehospitalization or mortality over the course of the year after having well-being measured around the time of a cardiovascular hospitalization. And we found that well-being, measured multiple different ways, was important. Indeed, if you had one standard deviation greater amount of well-being, that led to a 12% reduction in the risk of mortality or rehospitalization. Despite that, there had been very little study in our population, our illness of interest, acute coronary syndrome. Does optimism and gratitude after you have a heart attack actually do you some good? And there'd been very little study of mechanism. How, if well-being is good, how does it do that? Is it some biological process that is cultivated or conferred by positive psychological well-being? Or is it health behaviors, people getting, for example, more physically active, leading to better cardiac outcomes? So we conducted the Gratitude Research in Acute Coronary Event Study, the GRACE study. And we looked at optimism measured 2 weeks after a heart attack or an acute coronary syndrome, and cardiac readmission 6 months later. We also looked at effects of these well-being constructs on biomarkers of cardiac health, measures of inflammation, measures of function of blood vessels, endothelial function. And we also looked at behavioral mechanisms. Was optimism associated, for example, with greater physical activity 6 months later, or with other kinds of health behavior adherence, really important to cardiac prognosis? So we looked at this in 164 post-ACS patients, a relatively small-ish sample for a longitudinal study. And indeed, we found that optimism, measured 2 weeks by the LOTR, post-ACS, predicted the number of steps somebody was taking at 6 months, independent of age and gender, independent of the severity of their heart attack, independent of how active they were before their heart attack, and above and beyond the effects of depression and anxiety. And this was also true for more global adherence to health behaviors, including diet, physical activity, and medication adherence. We also found the optimists were less likely to be rehospitalized, again, independent of age or medical comorbidity. And it did seem that it's very likely that these behavioral mechanisms may have been kind of most important in play here, because optimism was not particularly related to any of the biomarkers we looked at, the markers of inflammation or the markers of endothelial function, really suggesting that maybe behavioral effects of positive psychological well-being was the royal road. Similarly, when we looked at gratitude, trait gratitude, whether you're a grateful person just in general, didn't seem to be associated with health outcomes in this study, but more in the moment state gratitude for one's health or for being alive 2 weeks post-ACS was associated with increased physical activity or with increased adherence. Okay, so that all seems important. Positive psychological well-being is associated with superior cardiac outcomes. That seems true both in healthy populations and in people with an ACS. And physical activity may be at least one mechanism / mediator for this beneficial cardiovascular effects. And plus, if you can get people more active, that has a whole host of health benefits. But can you actually increase a heart attack patient's and ACS patients' well-being? You know, can you help them feel more happy, more grateful, more optimistic? Or is it one of those things you either got it or you don't? You're always going to see the glass half empty, or you're always going to see the glass half full. Well, fortunately, when we started to think about this problem, we ran into a very large literature on something called positive psychology interventions. These are interventions that have been studied for many years that look to cultivate, enhance, develop in a very deliberate and systematic way well-being constructs, things like gratitude or optimism, or leveraging past success for future sort of projects or needs, using one's personal strengths that one has identified, those kinds of things. Turns out that these have been studied in more than 5,000 people in randomized controlled trials and lead consistently, and in some cases durably, to increased positive affect and lower levels of depression. And the cool thing is, as opposed to some other kinds of psychological interventions, they're super fun. A lot of these activities, things like writing a gratitude letter, or thinking about good things that happened in your day, or thinking about a strength you have and using it in a new way. People really like them. They don't require a lot of sophisticated training of trainers, and they're relatively straightforward. But most of these studies of positive psychology interventions have been done in healthy college students. This is serious business, some would say. This is like life and death. This is somebody just had a heart attack. Can you actually boost somebody's well-being in that context? And even if you adapted a positive psychology intervention for these people, would it really increase their well-being? And even if it did, would that increase their physical activity and thereby improve their cardiac prognosis? So we looked at this question in our PEACE project, Positive Emotions After Acute Cardiac Events. So to develop a positive psychology-based intervention for patients with an ACS, kind of from scratch, rather than kind of trying to make something up or pick something that existed and kind of trying to adapt it to cardiac patients and then testing it in a big randomized trial, we instead tried to use the approach kind of created or identified by Linda Collins called the MOST process, multi-phase optimization strategy. This is a strategy derived from engineering, and to some degree, it's really a correlate or an analog of drug development, where people, develop a compound and they look at the different ingredients of the compound and they look at different doses before actually testing it in large randomized trials in humans. In the MOST strategy, there's a preparation phase where you review literature, where you conduct qualitative or mixed methods experiments, where you conduct small pilots to begin to craft an intervention. You have an optimization phase where you use factorial design or other kinds of experiments to really look to optimize and identify optimal components of your intervention. And then and only then do you test it in a large, well-powered randomized controlled trial at your target of interest. So in PEACE 1, our preparation phase, we conducted a review of existing positive psychology intervention programs, and then we conducted a mixed methods study in ACS patients. We interviewed 32 ACS patients, first in the hospital, and then 3 months later, we did hour-long semi-structured qualitative interviews along with some quantitative assessments, looking at their experience of well-being, looking at their experience of getting physically active and barriers to that, and looking at the connections between those two. And it turns out that most patients did identify when they were feeling happier and more hopeful, they were more likely to exercise. And in kind of a glorious cycle, when people exercised, they felt happier or more hopeful. There's a sort of upward spiral theory that's sort of been developed based on this. And it really seemed true for these people that, there's a sort of glorious cycle of feeling good, exercising, feeling better, and so forth. And among those, on the quantitative assessments, among the people who weren't adherent to health behaviors before they before they had their ACS, actually were more likely to become adherent 3 months later if they were feeling more hopeful or happier in the hospital. And participants also, in addition to this, gave us all sorts of specific ideas about how we should deliver the intervention. They wanted it delivered remotely. They wanted to have some choice over the kinds of exercises they completed. And they wanted it to be about a couple of months long. So with that in mind, we conducted PEACE 2, which was a proof of concept trial of a newly created 8-week phone-delivered positive psychology-based intervention. So in this intervention, basically here's how it worked. We gave patients a treatment manual, a written treatment manual. And in the manual, it had a series, it had an introduction that talked a little bit about why boosting your well-being might actually be good for your health. And then each week, there was a section focused on an exercise, a positive psychology exercise that you would complete that week. The participant would then independently complete the exercise, write about it in their treatment manual and how it made them feel both at the time and then writing about it. And then each week would receive a call from a study trainer, in this case, a psychologist or social worker, to review the activity, how it made them feel, and then to introduce the exercise for the following week. The exercises you can see here as part of this piece 2, recalling positive life events, picking a personal strength and using it in a new way, performing acts of kindness, recalling a past success and leveraging it now for their health or other projects. And we gave them some choice about exercises. These are some pages from the manual. We introduced the idea of the well-being intervention and why in the world that might be good for your heart. We gave them some tips about how to get the most out of the program, about sort of being non-judgmental, trying something new. We realized this wasn't your usual thing that you would get from your doctor. We helped them to try to develop a lexicon of positive emotions. Many people didn't really have, a big lexicon of, how do you feel? I feel good was what we got a lot. And there's a big difference between feeling satisfied or feeling euphoric or feeling joyful or feeling pride. And we wanted to help people really identify and kind of bond with different kinds of positive emotions. And then each week they would get a specific exercise, as I said, some instructions and tips for completing the exercise, and space to write about the activity. So we completed this piece 2 proof of concept small randomized controlled trial in 47 patients, and we compared it to treatment as usual. And we indeed found that people who completed the 8-week intervention had greater improvements in positive affect, greater reductions in depression, greater reductions in anxiety. So that was good. It was feasible. Patients liked it. There was some improvement from psychological outcomes. Now we felt ready to take the next step and go to this optimization phase in the MOST pathway. In this phase, we wanted to figure out whether this intervention would improve not only well-being, but would actually have measurable effects on our targets of interest, health behaviors, and to some degree, specifically physical activity. And to do so, we wanted to make sure we had the right ingredients. We wanted to optimize different components of the intervention. So within this optimization phase, we wanted to compare positive psychology to a combined positive psychology motivational interviewing program. We thought, okay, well, maybe positive psychology will help to cultivate it and induce well-being, while you have another component, a health behavior, sort of an evidence-based health behavior, goal-setting related technique that's more specifically focused on physical activity. We weren't sure whether this would sort of be, synergistic, or whether actually trying to jam these two things together would distract from the focus or be too burdensome for patients. We were also interested in whether weekly or daily positive psychology activities were better for people to complete. The literature in positive psychology was actually mixed about how frequent it is that you do some of these activities to get the biggest boost in well-being. And finally, we wanted to know whether the addition of booster sessions added benefit or just more patient burden alongside our 8-week phone-delivered intervention. So the biggest potential change in the intervention as part of piece 3 was this combined PPMI program. So we thought, okay, if we're trying to hit physical activity, well, motivational interviewing could increase internal locus of control, reduce ambivalence, increase self-efficacy, all of which have been linked to greater physical activity. Positive psychology might also increase optimism and positive affect and impact depression, which have also been associated with physical activity. But also, beyond that, positive psychology does seem to boost constructs like outcome expectancy, self-efficacy, perceived social support that have been associated with greater engagement in health behavior techniques like motivational interviewing. So we thought that maybe the positive psychology not only would help kind of from a psychological standpoint to increase physical activity, but would also boost engagement in motivational interviewing and kind of supercharge it to work that way. The motivational interviewing component of our intervention was motivational interviewing kind of plus. We used the 5 A's model from behavior change theory, and kind of like in positive psychology where you completed an exercise each week there was a session-specific topic about identifying the importance and confidence of making behavior change, or managing slips to lesser amounts of behavior, in addition to setting a physical activity goal every week. And this component of the interventional manual looked like this. Again, like with positive psychology, there was something that happened each week. We gave people a rationale for why we would be wanting them to set goals to help them get moving more quickly, and gave them spaces to think about some of their prior activities, some of their goals, and so forth, at least in terms of this week. All right, so to make these three comparisons, is positive psychology or the combo better, weekly or daily physical or PP activities better, are booster sessions good or don't really add much? We conducted a factorial design experiment in 128 patients who had an acute coronary syndrome. Now, this is not, importantly, this is not an 8-arm trial in 128 patients. Instead, these are 3 dyadic 64 versus 64 comparisons upon which we compare the main effects. And this is a much more efficient way to answer all of these questions than trying to do 3 different experiments with 128 patients each, which would require, what is that, like 384 patients. So in piece 3, we tried to very efficiently answer some of these questions. So in this trial, we were interested in, first, whether this was feasible and acceptable. We wanted to know what rate of sessions people would actually complete the intervention. We were a little bit concerned, we enrolled people in the hospital, and there were a number of people we'd already noticed who, by the time we usually started the intervention, which was 2 weeks later, a number of them had been rehospitalized or had other medical events such that they really couldn't participate. So we wanted to know, are people completing like 70% of the sessions among all comers and among those who actually get to start it at 2 weeks? We also wanted to measure acceptability by measuring participants' ratings of the ease and utility of the positive psychology exercises in the program. And then we also obviously wanted to look at the impact of the program. Importantly, there is no control condition here, right? So there's 8 different conditions. Everybody is getting a positive psychology-based intervention. Everybody's having a phone call with a study trainer each week. And everybody's getting at least 8 weeks of an intervention. So the conditions varied, but it's almost like a comparative effectiveness trial. Everybody's getting something that we think is going to be, at least to some degree, good. So in piece 3, we found that 64% of all possible exercises were completed. Among those people who weren't early dropouts, of whom there were about 20%, they completed a large proportion of the exercises, 81%. And participants rated the ease and utility of the individual exercises relatively highly, nearly 8 out of 10. Did it work? Well, when we mushed everybody together across the 8 conditions and looked at just pre-post change, we indeed saw that there were improvements in physical activity and other health behavior adherence, as well as psychological outcomes. And these changes were statistically significant. Now you could say, but hold on a minute, in the 16 weeks after you have a heart attack, aren't you more likely to get physically active? Maybe. Aren't you more likely to feel a little bit psychologically better now 4 months out? Maybe. So we compared the effect sizes of the piece 3 interventions to our treatment as usual arm from piece 2. And indeed, we saw that the impact of the positive psychology-based interventions did seem to be substantially above and beyond kind of the natural history of post-ACS changes across most of our outcomes. And then for our primary aim and main goal of piece 3, we looked at between group comparisons. Now, again, we didn't necessarily think we would see statistically significant differences, given that patients in all these conditions and all these comparisons are getting a pretty active quote unquote control condition. But we did see that booster sessions were associated with greater MVPA. We saw that motivational interviewing, when combined with PP, was associated with greater overall health behavior adherence. And we actually found better outcomes with weekly positive psychology exercise completion. So this then led us to make what we thought was our more optimized intervention. The booster sessions were effective, but patients kind of hated them. Our booster sessions weren't very good, if I'm being honest. They were kind of reviewing what we'd done in prior weeks, but they didn't provide any new content. And patients, they didn't end up being particularly long, despite the fact that it seemed like some additional contact and content was helpful. So instead of making booster sessions, we actually prolonged the intervention slightly to give them more contact and content over a longer period of time without having kind of empty booster sessions. We then wanted to test our new 12-week PPMI intervention, phone delivered with weekly positive psychology activities being completed, compared to motivational interviewing alone in preparation for what we hoped would be our big trial. So this would be piece 4. And in this small randomized pilot trial, what we thought our best force would be, this is the intervention manual. And these are the 12 sessions that we came up with. You'll notice a couple of things, or at least I'll point out a couple of things. One is that we started to modularize the intervention. So patients found it a little, the exercises were a little bit all over the place. And so we actually tried to make it a little more cohesive with gratitude-based activities, strengths-based activities, and meaning-based activities, which also included optimism. But the bigger change we made, or I think the most important change we ended up making, was really focusing on review and skill building. So at the end of each of these modules, we had a whole week just thinking about how to use these skills in daily life. And every week at the end of these sessions, the trainer would not just review the exercise, but talk specifically with the patient about how you could, kind of reflect each of these activities into something that happens in your daily life. You're never going to write a gratitude letter to somebody every day for the rest of your life, but you may be able to express gratitude verbally, in writing, even in your mind more frequently, and that may boost your gratitude sort of overall, and that may have beneficial health effects. So in this piece for RCT, small pilot of 47 patients, we found even higher rates of completed sessions and high ratings of ease and utility of both the PP and MI components of the intervention. And we saw pretty substantial improvements compared to MI alone in positive affect, our primary psychological outcome, and in physical activity, both moderate to vigorous physical activity and steps per day, both as measured by accelerometer. So we now feel ready to kind of take the next step in terms of a larger randomized controlled trial utilizing this piece 4 intervention. This piece 4 randomized trial it seemed like it worked well. We were able to modify positive affect, which is important because positive affect alone has been associated with superior sort of survival and with lower rates of cardiovascular disease in healthy and medically ill populations. And most importantly, it had promising effects on our target on physical activity, which, as we've discussed, is strongly associated with superior health and prognosis. So we hope to get funded to be able to do this large randomized controlled trial testing piece for versus a control condition to see if it truly and durably impacts physical activity and by extension has effects on cardiovascular prognosis. So while we've been doing this work in ACS patients, we've also been interested in whether these interventions can be helpful for other populations with medical illness. And type 2 diabetes came to mind to us and to some others as a good population in whom well-being may be important. So type 2 diabetes is a more chronic illness, and it's a common and prevalent one. More than 25 million Americans have type 2 diabetes. Its prevalence continues to increase. People with type 2 diabetes are at risk for heart disease, other kinds of end organ complications, and mortality. And unfortunately, though physical activity is really good for prognosis in type 2 diabetes, the vast majority of type 2 diabetes patients aren't able to reach recommendations for physical activity. And as with ACS, psychological factors may well play a role. As with ACS, probably most patients don't have a clinical psychiatric disorder, but many T2D patients do have increased levels of distress and low levels of psychological well-being. And research has found, as in other populations, low levels of psychological well-being, above and beyond the effects of anxiety and depression, appears to be associated with physical activity and medical outcomes. So it appears to be an important target and an important possible pathway to helping people get more physically active. So we sort of walked down the steps of most, as we did with ACS patients. We prepared by conducting a review of the literature, some qualitative work with patients. Patients with diabetes, not surprisingly, wanted a little bit longer intervention and particularly wanted to focus on perseverance. Not surprising given both the chronic nature of diabetes and the fact that there are so many things that diabetes patients need to take care of, need to check, need to monitor. It really is, truly a marathon rather than a sprint. We conducted first a PP alone pilot and then a one-arm pilot of our combined positive psychology motivational interviewing intervention and found, relatively positive effects in terms of feasibility, acceptability, and preliminary impact. This then led us to our optimization phase, and we had a slightly different design for our optimization phase with this program. This was called the Behold program, boosting emotional health in outpatients living with diabetes. In this optimization phase, we had kind of a meta trial. We randomized patients with diabetes, with type 2 diabetes and low physical activity to either an 8-week trial or a 16-week trial. And the 8-week trial was 8 weeks of PPMI versus essentially a matched MI-alone control condition, or 16-week PPMI versus sort of health education condition. And the idea here was to assess the efficacy of these 8 and 16-week interventions versus time-matched control conditions, but it also allow us to sort of compare the 8-week flavor versus the 16-week flavor in terms of which kind of PPMI intervention might work better if it looks like it works at all. So as with piece 4, we've gotten kind of more modular with our approach to ACS patients, but you can see that some other exercise activities are snuck in here, like using perseverance and humor, which the patients with diabetes really appreciated more, I think, given the chronic nature of their illness. So in the Behold 8 component of the trial, 8 weeks of PPMI or MI alone, the PPMI intervention looked really strong. 93% of all possible sessions were completed. Rates of ease and utility of both the PP and MI components were very high. And we saw pretty substantial improvements in both positive affect and in physical activity, whether you measured MVPA or steps per day using an accelerometer. And that was both at the end of the intervention and then 8 weeks later. Interestingly, in Behold 16, rates of session completion were lower. There was a slightly lower sense of acceptability, and the impact was smaller, both in terms of the comparison condition and in terms of the comparison with the interventions in the 8-week trial. At 16 weeks, the PPMI intervention did appear to have bigger effects on positive affect and physical activity. But again, these effects were substantially smaller than what we saw in Behold 8. And this was consistent with patients' qualitative feedback. Though, diabetes patients had really reported wanting a longer intervention, doing essentially 4 months of positive psychology exercises and the phone sessions and goal setting ended up being kind of a lot. And in the end, 8 weeks felt like a sweet spot for the phone-delivered weekly treatment manual package, with potentially some, booster content or additional content or other modalities helping to sort of keep them going beyond that. So, everything I've told you about so far, our ACS and type 2 diabetes interventions that now feel ready, an 8-week diabetes-related intervention and a 12-week ACS intervention feel ready for a randomized controlled trial. All of these have been delivered by phone. But we've been increasingly interested in mobile health applications, digital health applications, and whether they can either alone or as an adjunct to our phone-delivered remote applications can be of benefit by sort of promoting well-being and promoting physical activity. And we really hit on text messaging as the best modality for this. In our populations, text messaging has felt so far like the best fit. 97%, I think, of adults use text messaging at least once a week. People really react to text messaging. 90% of text messages are read within, I think, 3 minutes. And text messaging doesn't even require you to have a smartphone. You can just have any kind of cellular phone. And in our populations with really varied socioeconomic status, comfort with technology, varied ages and functional status, something simpler like text messaging as opposed to a mobile app that you have to have a little more sophistication to utilize, and you have to download the app and you have to interact with the app. Text messaging just felt like the right fit for our work. So we went down the path of trying to study text messaging. We started very simply by sending 14 text messages, 1 text message per day to 40 ACS patients. 7 of these messages were positive psychology based. 7 of these messages were physical activity based. We just wanted to see if we could do it, whether it would work and whether it would have any impact. The good news was we were able to deliver whatever that is, 560 text messages successfully to all 40 patients. And we saw some improvements of some psychological metrics and self-reported physical activity. Patients did tell us, however, that that it was pretty clear that these text messages were off the shelf and they wanted content that was much more individualized to them in their situation. And we began working with a medical student at Harvard named Sean Legler, and he helped us to really craft a more adaptive, flexible approach to text messaging. This messaging approach was very similar to the Pandora music system. In Pandora, for those of you who haven't used it, you get a song, and this song has multiple attributes, and then you rate the song. You give it a thumbs up or you give it a thumbs down. And the program learns which songs and which attributes you seem to like. And over time, you get more and more songs that have more and more attributes that you have rated highly in the past. This program is very similar. We have messages with different attributes, and we have people rate them 0 to 10. And those that you rate more highly, you're going to start getting messages that you find with attributes that you found more useful. And so over time, ideally, the program is curating a set of text messages for you that is consistent with your preferences and your needs. So, here are just some, very simple examples. There are messages, for example, a message about altruism. And so that has a category attribute of positive psychology with a subcategory of altruism. It's, asking you perform a small act of kindness. So it's directive rather than just educational. And this one happens to promote more social connections, performing acts of kindness. And as you can see, there are other kinds of messages with different kinds of attributes. And then the way this works, this is a little bit of a hard to read slide, but essentially there's a participant and the participant gets a message. This is about health behaviors, about, getting rid of unhealthy habits related to high calorie drinks. So it's a barrier to healthy diet, habit related, and it asks them to replace a drink with water or other 0 calorie drink at least once per day. The participant really liked that one. They rated it an 8. Then they got a message about sitting time, and it provided education about sitting time and its effects. It wasn't directive. It didn't ask them to do anything. And it was specific to sitting time and sort of tracking. Participant didn't really love that one. So then the next message sent has to do, again, with diet and habit related things, but this one was an educational one. So you can see over time, the algorithm starts to curate messages, kind of probing to see whether you like certain kinds of messages that were similar to other kinds of messages to get a sense of what you like and what you don't. So we've started down the road of testing this adaptive text message intervention. We tested this in 16 patients who all got this adaptive text message algorithm over the course of 4 weeks. We were able to deliver the text message algorithm in almost all of the patients. And in general, patients really thought it was decent. They didn't love it, and we have some adjustments to make, but they found it completely unburdensome, 0.5 out of 10 on a 0 to 10 scale. So we know we've got low burden, and we've been really working to try to figure out what the kind of utility content focus should be. And in our Text for Health study, which is kind of our next step study, we're trying to address that. So some of the feedback we got were that, some of the content from the adaptive text messaging was interesting, but it didn't also really sort of push them to change their behavior in any particular way. So in the pilot randomized controlled Text for Health study, we're taking patients at cardiac risk who have suboptimal health behavior adherence. And they're getting, every day, they're getting these adaptive text messages that focus on promoting well-being, providing health education, that sort of gives them problem-solving techniques or increases their motivation. But also, each week, they have a goal-based message. They set a health behavior goal. And each week, kind of a different algorithm helps them check in about their goal, helps them set a new goal, and helps them figure out what they, kind of where they fell down, where they could get better. And, this is just kind of what it looks like on the screen. There are lots of yes, no questions. In this particular one, in this case, a person said, I'm going to walk 5,000 steps a day. They did it. Then they decided to set a goal of 5,500 steps a day. But these can be any kind of health behaviors. And our newer algorithm is much more, is a little bit more built out. We're able to talk about facilitators and barriers to changing behavior and provide more open-ended text answers. But you get the general idea that we have these adaptive messages, but then on top of that, we've got these goal-directed messages that we hope will, kind of analogous to PPMI. You've got something that's focused on kind of something people like and promoting their well-being and engagement, and then you've got something much more specific to health behaviors. So where does this leave all of us? This leaves our group in a both optimistic and tenuous place. On one hand, we've had success in developing and testing positive psychology-based interventions for promotion of physical activity in patients with diabetes and patients with acute coronary syndrome. And we've had some really promising effects so far. At the same time, we haven't yet conducted or even been able to initiate the larger randomized controlled trials that will really test whether we're having substantial and durable impact on physical activity and ultimately on cardiac prognosis. Similarly, with our text messaging, we have this novel text message algorithm that we think there's a there. It's very low burden. It can be adapted to people's preferences and needs, yet we aren't sure about the real impact of it yet and whether it can be added to our positive psychology program or it can be a standalone intervention to improve cardiac prognosis. So it's a tenuous time, but it's also a very exciting time. We hope to be able to conduct these randomized controlled trials. We also have other trials in patients with heart failure. Chris Solano from our group is leading that, and metabolic syndrome. Rachel Milstein from our group is running that. And we hope to develop kind of a suite of positive psychology-based interventions that help people feel happier, people more improve their function, improve their physical activity, and ultimately help them have better health. Before I end, I always wanted to acknowledge our team. Everything that I've just talked about stands on the shoulders of all the people who you see here. You know, completing even these pilot randomized controlled trials takes a village of a lot of really dedicated interventionists, research coordinators, cardiologists, diabetologists, psychologists, biostatisticians. And so while I'm presenting the work, I am immensely grateful to every single one of the people on the screen because they have been instrumental in allowing us to conduct some of this work. And you see among them really promising scientists, really promising young physicians now, or psychologists who've gone on to graduate school. And I just feel so blessed to have been able to work with them. So I want to acknowledge them before I stop. And with that, I will stop and I will take questions.
What a great talk. Thank you, Jeff. Yeah, we've got a lot of, I've seen a lot of engagement on the attendee side throughout the talk. I think people are really excited about it. Awesome. And I appreciate you doing it. I have a few questions here. I'll do some questions and then I'll sign off and let Ian say thank you and goodbye. First, I want to start with one of the questions that is really sort of, I think, rooted in the science of behavior change, experimental medicine model. One of the things I appreciated about your talk was the clear conceptual figure, looking at the different intervention components and the mechanisms by which they might improve physical activity, for example, in ACS patients. Jeff Burke asks, the PANIS scale assesses high intensity positive emotions rather than the lower intensity things. Do you have reason to believe that the intervention boosts positive emotion generally? Do you believe it influences more the enthusiastic, excited, big positive emotions versus serene and calm? And is one or the other better for promoting physical activity?
It's a great question, and I think it really gets to the heart of it. One of the things we really struggle with in this field, specifically in the positive psychology field, is that of measurement. So, Jeff, you're exactly right. So the PANIS is a very, the items on the PANIS are about like enthusiasm and activation. And the PANIS has been pretty clearly associated with superior health outcomes. But there are other kinds of positive states and traits that may be just as important or more important that the PANIS gets at much less. We've mostly utilized the PANIS both from our own and reviewers' requests because it has been linked to health outcomes. But Judy Moskowitz, who's done very similar work in diabetes and HIV and a whole range of other populations, she actually uses a different scale. I wish I could think of the name of it, but it measures kind of a kind of more varied group of positive emotions. And she too has found similar amounts of boost of positive affect. And it turns out independently, we almost created the same exact intervention. And so I feel pretty confident that it's not just the high activation positive emotions that we're getting at, but we haven't measured that specifically. And I'll just say, not to get us too far on a tangent, the other thing that we're really interested in is optimism. Right now, the only highly utilized scale is the LOTR, though there's a couple others, which really gets at a person's dispositional optimism. We think you can change optimism. We think there is such a thing as state optimism, but there's no state optimism measure. And given how much optimism is linked with superior cardiac health, we wish there were a great measure of state optimism to be able to measure that as well, because I think that would both get at your question, Jeff. I think optimism to some degree is at least not quite as high, high energy of positive emotion. And also it's a construct, optimism, so linked to health.
Can I piggyback and ask, in the PACE-ACS study, was there any evidence that change in optimism mediated the treatment effect difference on physical activity in the PPMI intervention?
There were, both with positive affect and optimism, there were some signals of that. Unfortunately, the trials are small enough that you can't see, you can't really reach statistical significance. And, to be honest, that's one of the reasons I'm most excited to do these big randomized trials if we're able to get funded to do so, not just to see, does this improve physical activity, but it'll also give us the power to do more mediation analyses and moderator analyses and to really start to, kind of dig into mechanism. Because when you have 47 patients or 60 patients, you can kind of get there. But if you have 280 patients, you can really start to understand more about what's going on.
Yeah, somewhat related, Richard Sloan pointed out that it's pretty rare to see these, durable effects, even maybe sometimes even bigger effects, 12, 24 weeks in the ACS patients. We saw something that was a little bit more probably normative in the diabetes patients. Any comment about that sort of durability and maybe magnification of effect over time?
Yeah, we were surprised by it as well. Certainly just about any health behavior change intervention, you see pretty good effects right when it's over, and then they start kind of sliding away. The fact that we did see greater improvements was really promising, and we really wonder whether there is kind of a sequential effect of promoting well-being and promoting particularly possibly high activation or high energy well-being. And that leads people to feel more ready and able to take on physical activity and maybe even more physical activity. But honestly, that's conjecture. And I certainly wouldn't claim at this point that, that there's this escalating effect. We definitely saw it in this one pilot trial, and it would be very exciting if indeed boosting well-being then leads to a more durable and kind of a growing increase in both well-being and activity. But again, that's for a big trial to really understand. And I wouldn't claim that it does that yet.
Sort of building on that, and I'm going to try to bundle 4 different questions into one question here. So thinking about the designs that you followed so far, getting a lot of information, relatively small sample sizes, using the MOST framework. First off, how many years did it take you to develop the intervention through the MOST framework? And in terms of thinking about whether it's race and ethnicity or socioeconomic status, using this framework in your studies, have you been able to also sort of decompose some of the intervention effects by some of these demographic factors?
Yeah, great question. So the first question is, it took us about 6.5 years to get all the way down in the PEACE project. It took us about 6.5 years to get all the way down that process. We were really, really lucky. There was a program announcement from NIH that was actually looking for very specifically someone to use the MOST model to develop the health behavior intervention. It was like, catching lightning in a bottle. It's not something we ever saw before. And we were like, oh my gosh. So we were lucky enough to get funded to do this at like an R1 level grant to actually take the time to carefully develop an intervention. And so it's been great. And it took us about 6.5 years. We haven't yet gotten funded to do the bigger trial. And so that's on us to really be able to make the case strongly that a big randomized controlled trial needs to happen. And then the question about sort of parsing apart different populations, whether it's by age or socioeconomic status or race, we've looked at it a little bit in a couple of different ways. Again, a big trial would help us a lot, but first, in our biggest trial, the PEACE 3, where we did have 128 people, we looked at predictors of both dropout and effect. We were wondering, for example, whether underrepresented minorities were more likely or less likely to drop out, or whether there were other predictors of dropout. And we really didn't see any predictors of dropout. We had a relatively small number of dropout, but even kind of numerically, it looked like, the people that we enrolled stayed in the project. A bigger question is, and we really didn't look at this, what was our proportion of people who enrolled? Once we had, for example, an underrepresented minority in the project, they stayed in the project and did about as well as everybody else. But was it the case that we were approaching 4 underrepresented minorities to get 1, whereas we would approach 2, white men or white women? That is something we haven't answered, but we've got that baked into our next trial designs. It's a really important question, and we haven't. But we know there's not gross differences in efficacy or dropout from what we've been able to measure, but we're not quite there yet.
Last question from Josh Smythe. He says, look, sometimes you're doing some cool tailoring, and it seems like there are things that participants prefer and maybe boost engagement, and some that are sort of best for outcomes. And as you showed, sometimes those don't overlap. Booster sessions, they don't like them, but it seems like they're beneficial. How do you think about weighing that out?
It's a great question. I mean, this is one of the things we struggle with the intervention is, for example, and I think maybe you're kind of getting at this, like, what if we give people a whole bunch of messages they really love that don't do them any good? They're like, this is great. And it's not like leading to any behavior change. I mean, yay. I mean, it's a good question. And I think we've tried to get at that a little bit with this more combo where we've got the adaptive messaging that really fits people's preferences and our, hoped for needs, but we've also got this kind of more like routine goal setting. It's like you're going to get these goal setting messages whether you want to or not. You don't have to engage with them, but we're going to kind of hold your feet to the fire to the degree that you'll allow it to actually set health behavior goals, and we're going to ask you how it went, and we're going to have you set another one. And so that's been our compromise with that. But it's a great, we struggle with this. Asking people's preferences is not as simple as you really like Guns N' Roses. It's unless you think listening to Guns N' Roses is going to help your cardiovascular health. And so preference is one thing, but whether it improves health behaviors is another.
Hey, Jeff, this is Ian. Thank you so much for presenting to us. I know you presented on behalf of SOBC, but also on behalf of our Roy Ball Center at Columbia. I just really appreciate the work you're doing. I think we've been working really hard to try to figure out how to engage patients in interventions, and your work on sort of working on the more positive side as opposed to the negative, and paying a lot of attention both to effectiveness, but also to the extent to which your patients are engaging in your interventions in the first place is something that we definitely can learn more from you about. And I think we're thinking about, maybe we can combine things also for maybe folks, using something more positive to get people engaged and involved at the beginning, and then maybe some of the other interventions you can bring in afterwards. And so, yeah, I think a lot of our investigators in our center look forward to sort of reaching out for you for advice on some of those questions.
Yeah, it's always, I mean, this is the thing. I mean, engagement both with research participants, but also like in real world settings is something, right. I know you as a clinician, struggle with, and we all as clinicians struggle with is, when you have a really enthusiastic research participant, that's great. But when then you go on the wards and you see 10 patients and not everybody is a super enthusiastic participant in their healthcare for a variety of very real world reasons, then it gets complicated. Has what we made actually fit just enthusiastic people? And we've been thinking a lot about implementation, and that's, in just small example, that's why we picked text messages. Most patients I see on the cardiac units aren't going to use an app. Maybe we'll get there, but most people get text messages, they can go with that, but that's about as far as they'll go. And so it's not very sexy. We try to do simple things that maybe aren't like the coolest thing, but I really worry about like the coolest thing for somebody who's working 3 jobs, or somebody who's got a whole bunch of functional difficulties due to their illness. Or, am I setting them up to have us fail them? And so we really try to think about that.
Yeah, I think that's been a theme of SOBC for this next 5 years. Also, is to think much earlier on about the implementation aspects, and so we don't spend 10-15 years developing an intervention that nobody can actually use in their life unless they're a really eager research participant.
Yeah.
But yeah, again, thank you so much for your time today. We're going to definitely reach out to you afterwards, and there's so much in common between our the work that we're doing, and hopefully we can even find some projects to directly collaborate on.
That would be great. That would be great. Thank you so much. And thank you so much for hosting me. I love to get a chance to talk about the work of our team. So thank you guys for reaching out and letting me talk about it.
Great. Have a good afternoon, everybody.